That's more arousal versus awareness. Okay? Awareness requires cognitive function. And awareness is knowing where you are in space and time. It is contents of thought. You require all these cognitive functions to be aware. Okay? Aroused, you only need wakefulness. Okay? Coma. Coma is basically you can knock out your reticular activating system, and your reticular activating system is basically what's responsible for your awakeness or consciousness. If you have an area that damages your bilateral hemispheres, or you suppress the bilateral hemispheres, then you will have depression of consciousness. You would actually have depression of brain function, and that can give you a coma. Bilateral hemispheric damage or suppression will give you a coma. Brainstem lesions or metabolic derangements, damages or suppress the reticular activating system, can be actually another aspect of what produces coma in a patient. So alteration in arousal, things that can cause it: supratentorial versus infratentorial versus subdural versus extracerebral versus intracerebral. Now, supratentorial means anything above the tentorium. So the tentorium is separated by the cerebellum and the brainstem and the cerebral hemispheres. Okay, so anything above the cerebellum and the brainstem is supratentorial. Anything below the cerebral hemispheres is infratentorial. Okay, subdural is below the dura, and that subdural space. Extracerebral is anything from subdural to subarachnoid. All these would be extracerebral because it's not in the brain parenchyma, it's in the meninges. And then you have intracerebral, which is actually in the brain parenchyma itself. So these are the structural areas that can be implicated in arousal. Metabolic can be in metabolic encephalopathy. Psychogenic can be chemical derangements that can actually cause alterations in arousal in a patient. Okay, so clinical manifestations of alterations in arousal. Level of consciousness, so is the patient awake, alert, they know who they are, where they are. Breathing patterns. Breathing patterns can be implicated when brainstem is being compressed. You can have chain stroke respirations. You can have post-hyperventilation apnea. And these are all stimulated due to carbon dioxide. Carbon dioxide is a potent vasoconstrictor, vasodilator. Carbon dioxide is what we is our intrinsic drive to breathe. It gives us our intrinsic drive to breathe. If we're not breathing, what usually happens is that we're building up carbon dioxide, we're building up carbon dioxide, building up carbon dioxide. When we build up carbon dioxide to a certain level, our brain says you have to breathe. Well, in these patients who have alterations in brainstem function, they can have post-hyperventilation apnea, where they have the respiratory drive is not working, or something's going on where they're not breathing like they're supposed to, and then they build up CO2. They build up CO2 to such a level where the brain says, oh my God, we need to blow this off. They breathe, hyperventilate, and then after they blow it off all the way, they go back into this apneic episode. Okay? And this is where you see these changes in respirations. Pupillary changes can tell you if the brainstem is being compressed. Remember we said cranial nerve 3 is in the brainstem. It is in the midbrain, and cranial nerve 3 is actually responsible for constricting the pupil. If cranial nerve 3 is being compressed, you can actually have pupillary dilatation and non-constriction. Oculomotor responses, doll's eyes. When we're doing brainstem testing, we look at doll's eyes. Motor responses, do they withdraw, do they localize? or the following commands, and things like that. So oculomotor responses, doll's eyes, okay? When we're doing brainstem testing in a patient, and we don't do this on patients who are awake, we usually do this on patients who we're thinking that this patient is probably brain dead, and we can't get a response from this patient. The patient's off sedation and we're getting no response. That's when we kind of initiate these things. Doll's eyes, if you've ever, if you're a girl or a woman, and you've had a doll, or you're a guy and you have a sister who's had a doll, if you notice with doll's eyes, it kind of, this is where this comes from. If I turn my head to the left, my eyes kind of look up. And usually, when I was a little girl, I had one of those dolls too, and I remember, you know, wherever you turn the head, the doll will go in the opposite direction. So if I turn my head to the left, my eyes are going to go up. If I turn my head to the right, my eyes are going to go up back to the left. Now, that is a positive doll's eyes, and that's what we want. We want a positive doll's eyes, okay? We want, when we turn our head this way, for our eyes to go the opposite direction. When we turn our head this way, our eyes to go to the opposite direction. Again, that is positive doll's eyes. What we don't want is a negative doll's eyes, where I turn my head to the left and my eyes fall down to the left with my head. Or I turn my head to the right and my eyes fall down with my head to the right. That is a negative doll's eyes, and a negative doll's eyes means that you do not have brainstem function, okay? Or you may have some, but very low brainstem function, okay? And these are the things that we initiate when we're looking at brain death, when we're initiating brain death protocol. Caloric testing, and you're testing the vestibulo-ocular reflex. The vestibulo-ocular reflex is basically checking cranial 8, and we do this with co-caloric testing. We have different vestibulo-ocular, different degrees of vestibulo-ocular reflex testing. Cold opposites, warm same, cows. They can do vestibulo-ocular reflex testing with cold water or warm water, okay? When we're doing crude vestibulo-ocular reflex testing at the bedside, we usually use cold water, and we instill cold water into the ear. But you can do it with both, okay? And cows is cold, opposite, warm, same. This is only referring to the nystagmus that you see. Pouring the cold water in the left ear leads the eye movement towards the left and a direction of nystagmus towards the right, okay? That's a normal reflex, okay? So usually you look towards where the water is being poured in, but the nystagmus goes in the opposite direction, okay? With cold water. Warm same means that when you pour the water into the left ear, eye movement to the right, and the direction of the nystagmus is towards the left, okay? Cold, opposites, warm, same. So when you pour water into the left ear, the eyes are going to move towards the right, and the nystagmus is going to be towards the left. Now, you don't really see the warm water testing in practice. You see more the cold caloric testing in clinical practice, where we pour the cold water and we look for the response, okay? But I want you to remember caloric testing, vestibulo-ocular reflex, and it's actually cows, cold, opposite, warm, same. Pouring water into the left ear leads to movement of the left, eyes to the left in direction of nystagmus to the right. And then warm, same, pouring warm water into the left ear and eye movements in the right and direction of nystagmus to the left. Again, when you're saying cold, opposite, warm, same, you're talking about the direction of the nystagmus. You're not talking about the direction of the eye movement, okay? Remember, with cold water going in the ear, the eye is going to move towards where the water is being poured in. If it's warm water, the eyes are going to move in the opposite direction of where the water is pouring in. The nystagmus with cold water is going to go opposite direction, and the nystagmus with warm water is going to go the same direction as where the water is being poured in. Okay? And this is a vestibulo-ocular reflex, cold water and warm water. If you look at it, okay, cold water, pour the water into the ear, your eyes look towards the water, and the nystagmus is going in the opposite direction, okay? Eyes go towards the water, nystagmus in the opposite direction, okay? With the warm water, the eye goes away from where the water is being poured in, and the nystagmus is going towards where the water is being poured in. Same thing here, okay? This is more what we see at the bedside. It's cold, instill the cold water, eyes go towards the area where the water is being poured in, and then nystagmus goes in the opposite direction. This is what you want. All this is what you want, okay? You do not want the eyes to stay in the same direction. If you see the eyes stay in the same direction, or if the eyes just stay looking forward, that is a bad sign. That usually means that you don't have, you have a negative cold caloric testing, which means that you don't have brainstem function. Okay? Disorders of posture and stance. Again, when we're looking at patients with severely depressed mental status functioning, we're going to look at disorders of posture and stance, okay? Decorticate to the core usually means that you have cerebrum, no cerebral hemisphere function, but you have brainstem function, okay? Decorticate, no cerebral hemisphere function, brainstem function is intact. Decerebrate, you have no brainstem function and no cerebral hemisphere function. Remember, decorticate to the core, or it's flexor posturing. We don't really say decorticate and decerebrate anymore, but I just put that way because a lot of you know it that way. Flexor posturing is decorticate posturing, and that is to the core, and it usually means that you have no cerebral hemisphere functioning, but you may have some brainstem functioning, okay? Decerebrate, which is extensor posturing, and usually your hands extend, feet extend, okay, out also, and that usually means there's no cerebral hemisphere functioning and there's no brainstem functioning. Okay? Brain death testing, remember, you have to be warm and dead, okay? So if your body is cold, you cannot do, if the patient's body is cold, you cannot do brainstem function testing. The patient has to be warm and dead. So if the patient's core body temperature is 33, there's no way you can do brainstem functioning on this patient. You have to warm them up, make sure that they're normal temperature, normothermic, and then you can actually do your brainstem testing, okay? You have to make sure all completion of all therapeutic procedures are done prior to, so you're going to do your cold caloric, your positive, your ocular motor reflexes to check to see. The patient has to be unresponsive and absence of motor reflex responses. Patient has to have no spontaneous respiration, so they're apneic. That means that you can't do it unless the person is intubated, okay? No cephalic, ocular, or caloric reflexes. Isoelectricity on ECG. Remember, brainwave activity or ECG shows you brain activity. If it's actually flatlined, that means there's no brainwave activity. Usually means that there's no brain activity going on. And it has to be persistent for 1 hour and 6 hours after onset. So it has to stay going for the entire hour, and usually 6 hours after onset of symptoms. So if it's not 6 hours, you can't start doing the brainstem testing yet. I mean, you can, but you really can't document them as brain dead. And then you have to make sure that you have all these factors checked off prior to pronouncing someone brain dead. Okay? Cerebral death, irreversible coma, death of the cerebral hemispheres, exclusive of the brainstem, so you can have cerebral hemisphere death, but you can still maintain respirations. Remember, you can still maintain vasomotor function because the brainstem is still intact. Usually these patients don't know where they are, who they are, they're not waking up, but they can actually maintain their blood pressure, They can maybe breathe spontaneously on their own. The brainstem's still working, but the cerebral hemispheres are gone. So everything that's the cerebral hemisphere is responsible for is taken out. Wakefulness, all that stuff. Okay? We're going to start talking about speech. When you're discussing speech or anything, this means that it's not functioning properly and means that there's absence of it. So if I have dysarthria, it means that I have decreased ability to. If I have anarthria, it means I can't complete the function. Okay? What can cause dysarthria or anarthria? Laryngeal, palatal, lingual, or facial muscle paralysis. Remember, it's not aphasia. Usually if you have anarthria, a lot of times it's cranial nerve 7 paralysis or cranial nerve 12, and they have difficulty moving their tongue. So when they try to speak, it's like a drunken speech, blah, 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 like that. Okay, so they can't move their facial muscles in order for them to articulate appropriately. So they have like a really bad slur. Okay, dysarthria, they will slur. Anarthria, usually you can't understand anything they're saying with their because they're so slurred. Dysphonia or aphonia. Dysphonia, they have like a hoarseness in their voice, and this is the vagus nerve that is implicated. Laryngeal nerve damage, usually when you have an anterior cervical discectomy infusion because of a cervical spine injury or cervical spine disc herniation, they actually have to retract the laryngeal nerve, and because of manipulation of the laryngeal nerve, they can come back with some dysphonia. And sometimes it takes a little longer than normal to come back. So you have to really monitor it. Dysphagia or aphasia, remember the speech center dysfunction. Remember you have Broca's speech, Wernicke's speech, Broca's area, expressive versus Wernicke's, which is receptive, okay? Speech, when you're talking about fluent versus non-fluent, non-fluent is Broca's. It's usually difficulty expressing. Non-fluent, they can actually speak. It's just that they have no idea what you're saying to them, and their speech is completely inappropriate. So you ask them, what day is it today? And they tell you, there's a fire going on over there. They did not comprehend anything you say to them. They can actually formulate the words, they can actually speak very fluently, but their speech is completely inappropriate. Okay, so you have non-fluent, where it's like a Broca's aphasia, and then you have fluent, where you're suffering Wernicke's aphasia. Okay. Memory, immediate recall, recounting events. Long-term memory, recall, we're talking about maybe delirium versus dementia. Those two, remember delirium, they have no memory of anything. Dementia, they can actually remember long-term, but short-term is compromised, okay? Abstract reasoning, you have to have higher cortical function in order to have abstract reasoning. So that means your left frontal lobe has to be functioning. If you do not have higher cortical function, meaning you don't have, your cerebral hemispheres are not working, you cannot depict a proverb. You say, if you live in a glass house, don't throw stones. Someone who do not have higher cortical function would say, really, literally, you cannot throw stones if you live in a glass house. They will not understand the proverbial aspect or the proverbial interpretation of what you're saying. Okay, it requires a higher mental function than their capacity if they have a disease process in that area. Motor integration, praxia. Praxia is the ability to perform fine motor acts or ability to perform actions, and it's learned actions that you have the ability to perform. Apraxia is the inability to do that. You also have dyspraxia, where you have some, he hears and understands commands, but unable to perform the action. They have a lot of studies that autistic type kids have some dyspraxia associated with it. You remember your apraxis, inability to voluntary movement without any deficits. And I may have dressing apraxia. I can't dress myself. I can have speaking apraxia. I can have apraxia just to do a normal task. It's something that I've learned, something I know, but then I just can't perform it. Writing apraxia. You can have different inability to perform voluntary motor. Okay. So in a dyspraxic person or apraxic person, you have the request and they understand what you're telling them, they want to perform what you're telling them to do, but the muscles and the integration that you need to do it is not working. And that's usually what we have when we have apraxia. Nausea is the ability to recognize familiar objects. Agnosia is the inability to do that. If I put a key or like a pen in your hand, you should be able to just feel it with your eyes closed and tell me what it is. If you can do that, that's nausea. If you cannot do that, that is agnosia. You have visual agnosias, where you can actually, the left occipital and temporal lobe lesions. You have auditory agnosia, where you can't really hear or understand what you're hearing. And then somatosensory cortex agnosia is the inability to feel. So you can have visual, auditory, or somatosensory agnosia. Now I'm going to stop here, and then we're going to continue in a few.